Aye.
Anyone opposed? Any abstentions? The minutes are unanimously approved, which we'll move on to item number 4. Item number 4 is our recommendations from the October SURG meeting discussion. And what we're going to do is go through all of the recommendations just quickly to remind everyone, and then we'll come back and have the discussion on the each recommendation. All of the recommendations are on the slides. The first one was RS3, which is leverage existing programs and funding to develop outreach response providers and or personnel that can respond to any suspected overdose, or to those who are provided treatment for an overdose in hospital emergency room /EMS, and offer follow-up support, referrals, and services to the individual and loved ones following an overdose. Providers and or personnel to be deployed to anyone being released from institutional and community settings, such as hospitals, carceral settings, and other institutional settings, who is being discharged post-overdose or suspected overdose. Ensure this recommendation is included as the build-out of Nevada's crisis response system is occurring, so that tailored intervention for individuals who have survived a non-fatal overdose is included. The recommendation was that the harm reduction recommendation number 3, increase support for harm reduction based post-overdose outreach with public safety, including wraparound services for surviving family members and or post-mortem services for family. For example, the services could be funeral related, housing needs, healthcare, counseling, or a warm handoff to treatment for substance use order. And the recommendation was that this would be remanded back to the response subcommittee to combine these two recommendations. As you can see, Ms. Johnson noted the intent to rework HR 3 to combine it with RS 3, but because it was under harm reduction, additional support was needed from the response subcommittee. The next recommendation was, did I read the wrong one? Oh, no. Okay.
No, I think, sorry, they are in a different order on
Okay.
that other sheet. I'm sorry about that. I was just trying to fix that on the other one, but I think we'll just have to adjust. I apologize.
Okay. That's all right. RS1, evaluate current availability and readiness to provide comprehensive behavioral health services to include but not limited to screening, assessment, treatment, recovery, support, and transition for re-entry in local and state carceral facilities. Recommend the allocation of funding to support the development of a Medicaid re-entry Section 1115 waiver to increase health care for people leaving carceral facilities and to support readiness of carceral facilities to implement the 1115 waiver. Recommend legislation to require Department of Healthcare Financing and Policy to apply for and implement the 1115 waiver to increase healthcare for people leaving carceral facilities. Ensure there is an evaluation of readiness for planning and implementation. Treatment and recovery, recommendation number 2 was to implement follow-ups and referrals and linkage of care for justice-involved individuals, including individuals leaving the justice system. The recommendation was to combine these two recommendations, and that was pushed back to the response subcommittee to do that. Moving on to the next. Which is response subcommittee number 2, understand the true cost of implementing wastewater-based epidemiology in Nevada and its ability to support community response plans. And Vice Chair Lee said she agrees with the spirit of this language, but what does it mean to understand the true costs? So she recommended rewording to direct an agency to conduct a feasibility study, and Chair Ford asked this to be sent back to our subcommittee to be reworked. Next one is response recommendation number 4, review the operations and lessons learned from Clark County's overdose fatality review task force when that body's report is released in December 2024, and take this into account when supporting legislation to establish regional overdose fatality review committees, allowing flexibility as to the makeup and practice, and for the OFR to remain at the county or regional level as needed to effectively identify system gaps and innovative community-specific overdose prevention and intervention strategies in accordance with established best practices, such as the Bureau of Justice Assistance's Overdose Fatality Review, a Practitioner's Guide. And Chair Ford recommended remanding this back to the response subcommittee to wait for that 2024 report from Clark County's Overdose Fatality Review. And Vice Chair Lee recalled that Assemblyman Orlicker, who is a doctor, carried this bill during the 2023 session, but it was heavily amended, limiting it to Clark County. So there was a request to invite Assemblyman Orlicker to review the process and then do some additional work on this recommendation. And the last recommendation was RS5, understand what coroners and medical examiners currently test for and make recommendations to a specific agency or other sources to fund personnel and resources for independent medical examiners for investigation and reports to specify the cause. It was suggested that the committee get additional information from the coroners or medical examiners from moving forward. And I would add that we have invited Dr. Lee, who's the Washoe County Medical Examiner, to be here at this meeting. And Chair Lee stated that she does not support this recommendation if the intention is further criminalization of overdose to further the war on drugs. This would make people lose trust in the Good Samaritan drug overdose law and the tension with the drug-induced homicide law. And Ms. Johnson echoed concerns similar to those of Vice Chair Lee. And it was documented that our coroners and medical examiners in the state do not receive adequate funding to be able to scale up the investigations as needed right now in terms of doing expanded panel testing. So she being Ms. Johnson recommend the response subcommittee learn about the funding caps for these types of medical examinations in advance of funding any type of independent person. So we'll go ahead and move back to the first recommendation. And
Yes.
I'm sorry.
I was just going to note, I'm going to switch and share a different screen, and the order in which you saw those recommendations was actually based on how they were ranked at the October meeting. So that's why recommendation number 1 did not appear first, but I can go to wherever you would like me to go, Chair Kearns, on the working document.
We can go ahead and start with recommendation number 3. One thing I would add is that we did reach out to the for harm reduction, and that was the prevention subcommittee who originally really worked these recommendations to see if we could get any guidance from them. And what the suggestion is that we take out the word "and loved ones" out of the parentheses from the recommendation, and then put in parentheses, for example, surviving family members and or post-mortem services for families. So if you look at the recommendation, just to hopefully make that a little clearer, it would read: leverage existing programs and funding to develop outreach response providers and or personnel that can respond to any suspected overdose or to those who are provided treatment for an overdose in a hospital/emergency room/EMS, and offer follow-up support, referrals, and services to the individual and loved ones. And then in parentheses, put, for example, surviving family members and or post-mortem services for families following an overdose. And then the rest of the recommendation would remain the same. Is there any discussion from the committee members on this recommendation?
This is Shayla Holmes for the record. I would agree with the recommendations made by the harm reduction subcommittee. That I think that that was really along the lines of what I was considering as well when looking at how we would merge these two. And I can't think of any other way, but both really do get to the heart of the same request. So I would I would go with what their recommendations were, is my response.
Thank you, Vice Chair Holmes. Christine or Nancy, do you have any comments on this one?
I'm fine with it, but I'm wondering if we could make it even more concise and just say any persons of concern. Or is that just too general?
You mean where it says services to the individual and persons of concern?
Yeah, instead of, kind of itemizing family, friends. But if you just did it anyway, persons of concern. But again, I don't know if that's too general. Either way, so I'm fine with it.
Yeah, I had that question because I said, what if it wasn't a family member? Well, what if there were no family members and it was maybe a significant other? So I did put that to them. This was their recommendation. Because I said, they may be estranged from family, so it may not only be the intent of prevention's responses was that they really were targeting them to family members.
I guess, but family's
No.
got a pretty broad definition these days.
I agree with you. I do agree on that one. Vice Chair Holmes, what do you think? And concerned individuals?
Yeah,
And
I
loved
really,
ones?
the Shayla Holmes, for the record, I really like that thought process. I appreciate both bringing that forward. I think back to like how guardianship legislation is written, and I think they call them persons of interest and have persons of interest defined. And that's like anyone with, I'd have to go back and look at it, but it's like anyone with personal connection. And so I do think persons of interest, it might be the way legislation is written. But this isn't necessarily a recommendation for legislation, but recommendation for a program for persons of concern or persons of close vicinity. I do think you guys are onto something and definitely agree with that concept that it would be more, I mean, we've got so many different forms of family, as Christine said, and I think having something that's inclusive of that's important.
Yeah, I agree. And I think we could put that in instead of and loved ones, but we could put the example, for example, surviving family members and or postmortem services. Could leave that in to satisfy the request of the prevention subcommittee. Rosalie, are you still on with us?
See, Rosalie, and I actually didn't see a DAG join today.
Okay.
Unless it was a new person.
She was on, but she's covering both. So I was just going to ask if we should vote on these each as we go, and it might be easier just to vote on each as we go than to wait till the end.
And I'll share it with no markup if that's easier for people to see what it now reads. So this is the area that we changed. But of course, the approval is for the whole recommendation.
Right.
And this is Nancy Limler, and I just have a thought about, it seems to me this is about clarification. My only thought is about, I like that we're moving away from strictly family, but because family is so broad and a lot of folks may not have what we consider family members, and I know I'm repeating what was already said. My only thought is about those impacted by the overdose. So you could be impacted by being present when someone overdoses or finding them or being involved somehow, and not be family. That's my only thought.
Yeah, that's a good one. I like that as well.
But then you're left with, well, what does that mean to be impacted, right? But I just think that's the gist of what this is after.
Any thoughts of adding that from the other committee members about those impacted by the overdose?
Christine Payson, for the record, I like that verbiage. And they can decide for themselves if they were impacted, if they identify as impacted.
Thank you for that, Christine.
Vice Chair Holmes
This-
also has her hand raised.
Please, Vice Chair Holmes.
Thank you, Shayla Holmes, for the record. I agree with that. I like that consideration when you consider all people impacted. I think about when we have youth who have overdosed and being able to have a response to, say, their school systems or their other community groups who may be impacted. And by going more broad like that, it would allow for a program like this to have a wider reach and greater impact to the community as a whole. And then from a community response subcommittee, I think that really gets better at what we would want to see a program like this be able to do.
Thank you for that. I think that's a really good point that you bring up. So then if we amend it to include and those impacted by the overdose, as she changes it, were we going to just say those impacted by the overdose? Or we're going to keep also persons of concern?
I did take that out. I don't know if this screen hasn't updated. So it says to the individual and those impacted by the overdose, parentheses, for example, surviving family members and or postmortem services for families.
I think in the parentheses, sorry, Shayla Holmes for the record, maybe we could also add, like how Christine had, other persons of concern or vested interest. Since we are highlighting families in there, and we seem to kind of highlight families in those parentheses twice, maybe we can, or other persons of vested interest, something like that in there, or we just take the parentheses out. I don't know.
Yeah, my only thought with leaving the parentheses is that was at the request of the other subcommittee. So in trying to merge what they had into ours.
Christine Payson for the record, if we left the parentheses, which highlights the family, excuse me, could we add or persons with a personal and or emotional connection to the victim?
Shayla Holmes for the record, I think that sounds much better than the persons of vested interest.
Great contributions from the committee members. Thank you. So then we're to the point of, and those impacted by the overdose, in parentheses, for example, other persons with a personal and or emotional connection to the victim, surviving family members and or postmortem services for families. Any other discussion or recommendations? Okay, let's go ahead and vote on this one with the revisions as we just discussed. All in favor of moving this one forward to the SURG as a response subcommittee recommendation number 3, say aye.
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 Any opposed? Anyone abstaining? Okay, we have unanimous agreement on moving this one forward. So now we'll go to the next recommendation, which is RS 1. And again, this was the one where the treatment and recovery suggested that we merge what they had into ours. And in my reworking of it, what I had done was after state and carceral facilities, put in parentheses, for example, implement follow-ups and referrals and linkage of care for justice involved individuals. That includes individuals leaving the justice system. Actually, I think it's after the first paragraph. Well, we could probably put it after this, that other one you had it too, for the 1115 waiver. Because it kind of fits both, because that's talking about readiness and planning for implementation.
So here too.
I was thinking where you originally had it. Committee members, do you think we should put it under the first paragraph or the third, or both? After thinking about it, I think really probably the only place we need it is after the first paragraph.
Christine
Shayla Holmes,
Payton.
for the record, I would agree with that. Oh, so sorry, Christine.
No,
I was
yeah.
thinking the same thing, Dr. Kearns, is that I don't think it's necessarily to duplicate it, and getting it in at the first, I think, would suffice.
Christine Payson, for the record, I was just gonna say the same thing. The first one covers it.
Okay. Any other suggestions or edits for this one from committee members? Okay, so just for clarity, what we did is after RS1, evaluate current availability and readiness to provide comprehensive behavioral health services to include but not limited to screening, assessment, treatment, recovery support, and transition for re-entry in local and state carceral facilities. We added in parentheses, for example, implement follow-up and linkage to care for individuals leaving the justice system. So we'll go ahead and take a vote on RS1 with the revisions. All in favor, say aye.
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 Any opposed? Any abstentions? Okay, RS1 unanimously is approved. So we will move on to our next recommendation, which is RS2. The RS2 was to understand the true cost of implementing wastewater-based epidemiology in Nevada and its ability to support community response plans. Shayla, I can talk about the suggested revisions, or I'll leave it to you as this was your recommendation.
Shayla Holmes, for the record, either way I think is fine. I think the recommendation from Chair or Vice Chair Lee makes a lot of sense, and that it can be edited to something more specific to fund a feasibility study to identify the cost and benefits of implementing wastewater-based epidemiology in Nevada and its ability to support community response plans.
Yeah, that sounds good. My only thought is I wonder, do we need to make a suggestion as to who should be doing that feasibility study, or just a suggestion of a feasibility study?
Well, that's a tough call. I feel like the individual who came and presented to us from the University of Nevada, Las Vegas, I feel like they were very much so interested. But I also know that University of Nevada, Reno was doing similar work. So I wonder if that wouldn't be something that I don't know if we'd want to put like NCHI in here somewhere as perhaps the appropriate body, or if we would just want to suggest an open RFP, but I'm not sure where that would live, maybe under the Department of Health and Human Services. So maybe we encourage the Nevada System of Higher Education to conduct a feasibility study or to fund a feasibility study within the Nevada System of Higher Education. That's just thinking off the top of my head here that they might be the best ones. And really, when we look at across the board needing more research in all of these areas, that would be one way to incorporate our research bodies, which is, you know, our universities. I'll stop rambling now.
No, I think that's a good suggestion. My thought, and you already said it too, was whether there would be like a request for a plan from DHHS, maybe even the State Public Health Lab. I wasn't sure who would do that, but this, I think yours lays it out well. Any other thoughts from the committee members?
Sorry, this is Crystal Duarte for the record. I just wanted to make sure I had this last part right. The Nevada System of Higher Education is encouraged to fund such a study, or are they encouraged to conduct with?
Yeah. Sorry, this is Sheila Holmes for the record. I would encourage, I think it's that we would encourage to fund the Nevada System of Higher Education to conduct such a study. Not that we're asking them to fund it, but I think that we could make a recommendation that some of the account for Resilient Nevada dollars be allocated to the Nevada System of Higher Education to conduct a study, but not have them actually fund it themselves.
I'm not sure what to add for that last part. With funds from the Fund for Resilient Nevada.
Maybe at the beginning, put recommend funding the NSHE to conduct the study. And then at the end, you could be funding, could be from the Fund for Resilient Nevada, funding for this study. Shayla, does that meet the intent of what you were saying?
Yes, I think that works well.
Any other comments from the committee members? Okay, hearing none, we'll take a vote for.
I was sorry, Terry. Maddie had a good point. Do we need to ask for a motion prior to the vote? I'm not sure how that works.
Oh. Is I don't think we have Rosalie on with us.
I don't think it would mean we'd need to and undo anything we've done.
Yeah. So does a committee member would a committee member like to make a motion to for this recommendation with the edits as we've outlined here?
This is Shayla Holmes. I'd like to make the motion to recommend this recommendation go forward as edited.
Thank you. Do we have a second?
This is Nancy Lemler, I second.
Thank you for that motion. So we'll vote on this one with the revisions as made. Recommend the Nevada System of Higher Education conduct a feasibility study to understand the true cost of implementing wastewater-based epidemiology in Nevada and its ability to support community response plans. Funding for this study may be available through the Fund for Resilient Nevada. We'll go ahead and take a vote. All those in favor, say aye.
I,
Aye.
Aye.
Any opposed? Any abstentions? Okay, so RS2 will go forward as edited.
I think on this one, and I don't know if this is something Chair Kearns, you wanted to ask for, but we did need to gather some of this additional information so that each of the recommendations has a complete narrative explanation of how it has been rated for urgency. So some of the other committees, they filled in this other box that says just provide a description for how this will, the impact, capacity, feasibility of implementation, urgency, and how it advances racial and health equity. So we still need information in that regard on this recommendation.
Do we have anyone who'd like to volunteer to provide that narrative?
I'm sorry, I think I missed the first part of that. So I'm reading the highlighted, but we're needing to make implementation recommendations or,
No, I think what she was saying is we ranked those based on the impact, the urgency, and the capability. So just to put a statement in as to why we rated it as we did.
And to add a statement about how it advances racial equity.
Thank you.
oh man. I think we could state that we rated it a 3 because of the potential positive impacts. Except for I'm like at a loss as to what else we would put in there. I think without knowing what we put in for the other ones. Because it's not a high sense of urgency, right? It's like medium out of 3. If I remember, those were what, based off of a 1 out of 5?
It's actually only 1 out of 3.
1 out of 3. So yeah, it's like low. So it's potential. It has potential for positive impacts, but the true outcomes are unknown, which is why we're recommending a feasibility study. So that's why it's low on urgency and low on the other categories, because it has the possibility to have positive impact, but not in the immediate future.
I just added that the true outcomes and capacity are unknown, because I believe that would speak to both of those things. Is that why the feasibility is being conducted?
The only thing that I would add is from the health equity is that we may obtain additional data from areas that we don't have, such as if they can do this in our rural and frontier communities, that might give us additional data.
Sorry, I was continuing to go, but I don't know if that's what you were saying.
Yes, yeah.
I don't know if it can actually get that information at the level of racial and ethnic differences. So that's where I stopped.
Yeah. We may need to rework this a little further.
I don't think that, obviously a vote has already been taken, so that kind of thing can be done prior to the December meeting.
Just to add the supporting documentation.
To add this, yeah, to add
Yeah.
whatever we would like to appear in the report that describes the urgency, capacity, and impact on advancing racial and health equity. But I think we would need a committee member possibly to take that on.
Yeah, I think the biggest part of this is we don't really know what the impact is going to be, so that may be enough.
Should we move to the next?
Yes.
Okay. The next one on my list is number 3, which we already did, so I'm going to scroll past that. And the information in this, we already had all the information filled out for that one, so. And the prevention subcommittee had done so as well, so it's quite a long justification and explanation. And now we have arrived at number 4.
Okay, for number 4, that was about the overdose fatality review. And as noted from the legislation, it was requested that we reach out to the Clark County Opioid Task Force and also to Assemblyman Ornlicker, which we reached out to both. And currently the Clark County Opioid Task Force will begin, they haven't done anything yet. They will begin meeting in January of 2024. And their meeting information will be available on their website will be put up there as soon as it becomes available. And Assemblyman Ornlicker referred us to, was it Assemblywoman Cohen? Yeah, Cohen, and we have not heard back from her yet. So our recommendation at this time is that we put this recommendation for further review, because we need to wait for that study that's going to be done, or that report that's going to be done from the Clark County Overdose Fatality Review Task Force. Any thoughts or comments from the committee members? Hearing none, I guess I would look for a motion to put this recommendation down as for further review till we can at the very least get the report from the Clark County Overdose Fatality Review that's scheduled for December of 2024.
Christine Payson, I'll make the motion.
Thank you, Christine. Any second?
This is Nancy Lindler, second.
Thank you, Nancy. So we'll go ahead and take a vote for this recommendation to be for further review. All those in favor say aye.
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 Any opposed? Any abstentions? This recommendation unanimously will be put on hold for further review, which takes us to the next recommendation, which is why we asked Dr. Knight to be with us today. Understand what coroners and medical examiners currently test for and make recommendations to a specific agency and or sources to fund personnel and resources for independent medical examiners for investigation and reports to specify the cause of death and overdoses. And if you'll remember, if this was purely for prosecution, we had 2 members of the SURG who did not support this recommendation. So I would ask Dr. Knight, I know we had some emails back and forth, if you could talk about the testing that's done, the cost, and any recommendations you may have related to this this recommendation.
Great, sure, I'm happy to. Yeah, so again, I'm Dr. Laura Knight. I am a board certified forensic pathologist and the chief medical examiner and coroner for the Washoe County Regional Medical Examiner's Office, just for the record. So this is a complex question, and as Dr. Kearns said, we do we have already had some email exchanges about this, but for the committee. Let me start first with saying, that the situation in Nevada is that we have 2 medical examiner offices, one in northern Nevada, one in southern Nevada, located in Washoe and Clark counties. We also have all of the other counties that are not in those high population centers are served by sheriff deputies as acting coroners in those counties. They do not perform autopsy services. Those sheriff coroner counties then are able to refer their cases to the medical examiner's offices in Washoe and Clark for autopsy when they determine that they feel an autopsy is needed. So there's going to be some variation in practices, both in death investigation as well as toxicology testing throughout the state because of those systems in place. Nevada revised statutes say that the coroners in the rural counties must send any cases of suspected drug-related deaths to a forensic pathologist in one of the centers to perform an autopsy examination. Actually, the law says to perform an examination. It doesn't specify, but the point of that law when we went and asked for that to be put in place was to make sure that the coroners were not in those rural counties doing things like doing the toxicology themselves and not performing and having an autopsy performed in those cases. So that was one attempt we made to standardize death investigation. Another law that we got passed fairly recently in the last 4 years, I believe, was the law that states that the certifier of death, even in those rural counties, will put on the death certificate the cause of death determined by the forensic pathologist when the forensic pathologist has done an exam. And what that means is that the rural sheriff deputies cannot, take my beautiful report that says the cause of death is these 15 drugs combined. And they can't take that and sort of dumb it down for the death certificate, which is where the state gets the data from for state health and vital records. They can't just put drug overdose because we were seeing that, unfortunately. And so those 2 laws in our state have, I hope, improved things. I would recommend to this committee that it might be a good idea to study and measure compliance with those laws. That's not something that I as a medical examiner, even covering as much of northern Nevada, that's not really in my purview to see what those rural coroners are actually doing, I guess. So studying and measuring compliance with those laws would be a wonderful thing that might help standardize. And if we find that there is not compliance, certainly we could consider whether another system would better serve our state for death investigation in general. And that code, for whoever's typing there, is NRS 259.050 and 259.053. So all of that said, I can tell you what we do in the northern part of the state in terms of drug-related deaths, and I do think that we are doing what is right and what serves our state best, which is to do a very comprehensive toxicology testing on all drug-related deaths. Just because you find fentanyl or methamphetamine doesn't mean that that's the only drug that person had on board, and so we do a more comprehensive panel. Both of the medical examiner offices in the state in Washoe and Clark use a national laboratory called NMS, National Medical Services Laboratory, which is the premier postmortem toxicology testing laboratory in the US. They are on the cutting edge. They even have a research arm that basically anytime a new drug is detected, they synthesize the appropriate standard to be able to test for that drug. And so our testing here is actually very good. And for a state that does not have a forensic toxicology laboratory in state, we have to find another resource in order to be able to do that. And I think it's actually to our benefit here in Nevada to use this national laboratory that serves hundreds of medical examiners across the United States and has developed a very advanced level of testing. Now, again, that is what we do here in Northern Nevada. I can't speak to what testing is ordered in Southern Nevada, although they do use NMS labs. I don't know if they do very basic testing or expanded testing or expert level testing, et cetera. But we have developed the practice that whenever a death is drug related or suspected to be drug related based on our scene investigation and the person's history, we order an expanded panel of testing that includes all of the synthetic opioids and the newer drugs that are being detected. Xylazine is included on that panel. And then the laboratory, if they detect additional compounds that are outside the scope of that testing, they let us know. And so that's a really a fantastic benefit to using that laboratory as well. They let us know so that we can, at additional cost, of course, order the additional testing if they have detected something like one of the novel benzodiazepines, bromazolam, that we're now seeing infiltrating our drug supply. They let us know that, hey, we saw the peak for that, and if you want to order the additional testing, you can. So maybe I should stop there. I have more to say, but I should stop there and see if there are questions on what I've talked about so far, or if you want to go on with your discussion and then come back to some more things.
Yeah, I just had a question. This is Terry Kearns for the record. My question was, you talked about this being sent out. I'm sure this is sent out at a cost to both your office and the Clark County. And then if there's additional testing that needs to be done, that would then be an additional cost on top. Is that correct?
That is correct, yes. In my case, Washoe County and the other counties that my office serves by contract do bear the burden of that cost. And my office spent $289,000 on toxicology testing last year. We cover a total of 19 counties, including Washoe, in Northern Nevada and a few on the California border. And we're looking like we're going to be on track to spend over $300,000 this year, because the number of overdoses, of course, has just skyrocketed over my tenure here. Certainly, we've seen about since 2016, we're on track this year to see triple the number of overdoses that we saw in 2016. So a small portion of our budget for toxicology comes from grants with the CDC's OD2A program. That's only about $40,000. So the rest of it has been, directly borne by the Nevada taxpayers.
Thank you for that information. That does help. So let me ask you, and this may get into some of the other things you're going to talk about, but the toxicology results that you get are I guess, used for numerous reasons. So cause of death on the death certificate. That may also be used if in a prosecution, if it's a case that's going to be prosecuted, but may also be used in the reporting that's done on the public health side of the house. Is that correct?
Yes, absolutely. All of those are correct. We have multiple layers of input into public health through the death certificate. The purpose of the death certificate through vital records is generally for public health, and that data is housed within the health district. So the registrar of vital records is in the health district, and so when we complete a death certificate, that data is owned or is housed in public health. The other things that we do, yes, the toxicology may be used in relation to a prosecution, of course, with the district attorney, or even with the attorney general, and then the grant-based part of our public health role with the CDC OD2A grant, SURG grant, we actually input data directly into the CDC's computerized database. And that is the data, if you've seen any of the reports that are sent out monthly by OD2A that talks, they cover both survived overdoses as well as the lethal ones. And the lethal information is coming from medical examiners.
Do any of the other committee members have questions? I have more, but I wanted to open it up to the other committee members. And before I go on, I'll let you, I know you had more you wanted to say, Dr. Knight, so please continue.
Thank you. I think the other main thing was just to address, I had a question really about what was meant by independent medical examiners. You know, I kind of glossed over that word when I first read this, when you emailed it to me. And in hearing the discussion and the comments on this recommendation, I was wondering, were those recommendations for, or a recommendation for an outside independent party to come in and look at what we're doing, or just more funding for medical examiners to do the job we're doing already in the state?
I'm going to defer that question to Christine Payson. This was originally her recommendation. So can you address that, Christine?
Yeah, Christine Payson for the record. I would say it's for more funding for what's already being done, because it was explained to us by the DAs to move forward with a drug-induced homicide prosecution. They would need a very specific cause of death, and even if it's polysubstance on board, but to be able to explain it to a jury what actually caused the death, and that it was a case-by-case, very expensive process, and to have a pool of people on board that could be tapped to help move those cases forward. But it would be funding for that.
Okay, I understand that. I think the issue might be bigger than that, and that our medical examiners are potentially underfunded if there's a perception that we're underperforming in that area. I do think I do have some information relevant to that, though. It may be related to the toxicologists being located out of state. That is part of the issue with the cost of prosecuting drug-related deaths here, because we do use this National Medical Services Laboratory, you know, for the defendant to be able to confront their accusers, including experts. That person would have to come here, the toxicologist performing the testing potentially, or an expert toxicologist from the laboratory. And so that can be costly, bringing in experts from outside. So it might be that there's more funding needed for prosecutors if they're going to be doing that. But overall, I mean, I would make the case that every level of the death investigation probably needs to be better funded as the numbers of overdoses increase, from the death scene investigation to the toxicology testing, to the forensic pathologists, you know, having an adequate number of forensic pathologists in our state to do the autopsies on the drug-related deaths, as is the gold standard nationally, as supported by the National Association of Medical Examiners, that we should be performing an autopsy on drug-related deaths. Forensic epidemiologists embedded in the medical examiners' offices to help us to put more of this data out, to get more granularity to the data about which specific drugs and their roles. And then finally, I know you all talked about bereavement services for families. That I've been advocating for years now for bereavement services and family advocacy to be also embedded in medical examiners' offices, and have gotten turned down by my county, at least, for funding for that the last 2 years in a row. And I will continue to ask for it, because I think it's very important to have that family advocate. And there are offices in other states that have great model programs that have been used, and that would be for drug-related deaths as well as for, you know, just the other deaths that we handle. But family advocacy and bereavement is a huge movement that's going on right now in medical examiners' offices. It's a kind of a newer development, or something that's resurged after funding was decreased, you know, during the early recession, and now we're coming back and trying to say we would like to have these programs again, or if we've never had them, we really do need to have them. So certainly I understand the need for prosecution, but we also need to be able to handle the number of deaths and to do it well, and to have all of the key players in the medical examiner's office embedded if we're going to create this more holistic wraparound service from the postmortem death care side.
Thank you for that, Dr. Knight. And I agree with everything you said. And I think, with this recommendation, because it was brought forth originally from the law enforcement side and for prosecution, it's, in my opinion, hard to stovepipe it for just that. Only because you do have such a multi-pronged customer base, if you will, in providing the data through CDC reporting. I know also provide it to task forces, people that have asked for it for their groups. So maybe the better way to do this, and Christine, I don't want to change your recommendation, is really more for additional funding for medical examiners for all of those things that you outlined, for toxicology, for death scene investigation, for forensic pathologists, forensic epidemiologists, for the data and data sharing, and then the bereavement services and family advocacy. Christine, like I said, I do not want to water down your recommendation, so I just wanted to get, first of all, your thoughts on that.
I'm fine with that. I just don't know then if it's kind of pooled together as one recommendation, then how would they decide how that funding would be dispersed amongst all those services? And would one or the other be left by the wayside or gotten a smaller piece of the pie?
I don't know the answer for that. Do you have any thoughts, Dr. Knight?
Well, these might be two separate issues. You know, that maybe you want to consider a different recommendation. I don't know what the committee's process is, but if truly the, you know, thrust of this recommendation was to have the experts involved in prosecution of drug-related deaths better funded, I mean, I would make a recommendation that says that, and then I maybe would consider the medical examiners and coroners resources separately. You know, it's not just the toxicologist though that's the issue in the prosecution cases. I mean, it is our medical examiners who testify in those as well, because if we did the autopsy and determined the cause of death, then we're going to be the ones called. And you can certainly use outside experts, you know, in your case, but if there are any attorneys on the call who know more, you're welcome to comment. But the confrontation clause really requires that the person who did the examination be there and be the one to testify, unless they're, you know, unless they're deceased or there's a really good reason not to have them. And cases have, you know, certainly run afoul and been appealed if that person's not there. So it's going to be our medical examiners here in the state who've done the autopsy who are testifying as to causation. And so having our offices better funded indirectly supports that. And the toxicologists are going to be from out of state, from the toxicology lab if they're called. I hope that clarifies. I don't want to take up too much time.
Christine, what do you think of that?
I guess we need to know what, if we're doing the same thing in the South, which I have reached out to coroner and several times and haven't been able to get some of my questions answered, and to see if they're using that same gold standard of lab testing. I mean, or if we just worded it that there's more funding to determine the specific cause of death, and then whatever that determination is used for, whether it's used for public health or used for prosecution or both, then that's where, you know, we're just trying to determine the cause of death and more funding to do that better.
Yeah, that was my thought. I don't think that you can necessarily separate out the two. The data is used for both purposes, or can be used for both purposes, not always, but it can be used for both purposes.
But I would think that the funding specific to determining the cause of death would need to be a separate recommendation from the wraparound type services.
So your feel, Christine, is we should have two: one for improved funding to determine the specific cause of death, and then the other is to increase or provide additional funding or improve funding for medical coroner offices. And that was all of the stuff we said that's underfunded currently: toxicology, death scene investigations, forensic pathologist, forensic epidemiologist, bereavement services, and family advocacy.
Yes.
And I think, Dr. Knight, that was your thought too, that it should be two separate.
Yeah, I think they're separate issues, and so the rationale for them might be hard to combine.
Other committee members, do you have thoughts on this?
Shayla Holmes, for the record, I have maybe a couple questions. Or maybe thoughts depending on this questions. I feel like our recommendation one that we worked on talked about post-mortem support for family impacted people. We worked really hard on that wording to be all encompassing. So I'm curious in regards to the coroner's office, what their family advocates and post-mortem support would look like, or if that is that program, like they're seeing that need, we saw that need, we're making a recommendation that that program needs to exist, and is that not the same thing? So I'm just curious as to the delineation between what family advocates and bereavement services via their office looks like versus what the program funding we're recommending under one looks like, because if we're making two separate recommendations, those seem very similar. So I'm not sure if that means we need to go back to one, or if we just need to make sure that if that gets funded, then these offices are also included as like outreach.
Just my opinion, and I'll ask Dr. Knight hers afterwards, is I think that those postmortem services that we talked to were specific for drug overdoses, deaths from drug overdoses. Whereas if I understood Dr. Knight right, hers would be for family advocacy and bereavement services beyond just those deaths, suicides, and other types of death. Is that correct?
Yes, absolutely.
But is that something that we can make a recommendation on under what we're tasked for within NRS?
I think our recommendation would be specific to the drug overdose types of cases. But, you know, it comes down to kind of just like Dr. Knight's services are to more than one community, these same services would likely be beyond just the drug overdose deaths. So I don't know if, you know, like the funding would go, oh, we would only be able to provide funding, and they would kind of have to meter out, you know, these people's, the time was spent for this, and then other funding would have to go toward the others. Dr. Knight, thoughts?
Yes, and in reality, if that position were funded through a grant or through you know, some specific state initiative for drug-related deaths, we would use that funding and apply those services to drug-related deaths, and then we would come up with the funding locally for the rest of the position. You know, if it was 0.5 FTEs for the drug-related deaths and the other 0.5 we would pay for, and we do have some funding from death certificate fees. I know already how I would pay for that, so I would love for that to happen, because it would be a great help to our community.
Okay. I have another question, if that's okay. And going back to the conversation between Ms. Payson and the ultimate original goal, and coming back to improving funding to determine the specific cause of death. And while I was listening to Dr. Knight, did I understand correctly that sometimes the specific cause of death is not related to the toxicology, but the toxicology is there showing that there is some substance on board? In which case, are we still only interested in improving the funding to determine the specific cause of death for the purpose of criminal intent? Which I know we've got some naysayers on that from the SURG as a whole. And is there any room to consider perhaps just improving funding for the toxicology piece, which, if I understand that correctly, sometimes we make budgetary decisions on what we're able to do because it's really expensive. And so if we were able to improve funding on the toxicology piece, maybe we can
come at it from a more public health benefit perspective, while also still giving the criminal intent piece the information they need to perhaps move forward with a case if that's where it's going? Would you get both of those out of improving the toxicology part as opposed to just improving the specific cause of death? I don't know if I'm just playing devil's advocate or trying to find a way to have a more amenable recommendation that has the likelihood of getting the both benefits through the greater surge.
Dr. Knight, again, for the record, if I can respond to that. I mean, I may be biased as a medical examiner, but I feel like my number one job is to get the cause of death right. And so we really focus on getting an accurate cause of death, not only for prosecutions when there was the criminal act involved, but also for public health purposes. If we were, for example, just doing toxicology testing and no autopsies on anyone, we would get the cause of death wrong a lot of the time, right? So we have to be funded for both pieces. And there are going to be people who have fentanyl on board but die of a pulmonary embolism. So we have to do both. We have to adequately fund our medical examiners doing autopsies and good death scene investigations to even know to suspect a drug-related death. And we also have to fund the toxicology. So I get where you're coming from, trying to parse it out. And I empathize with you on trying to rate recommendations that are good and likely to be taken. So you may have to parse that out. But from my perspective, we have to do both of those really well to get the right answer at the end of the day, both for prosecution and public health.
So it sounds like to me, maybe our best recommendation really is to increase funding for both, that we need to increase funding for toxicology testing and autopsies and all of the appropriate steps thereunto. And if I'm understanding it correctly, we would best serve you in trying to get additional staffing for that? Or is that just us trying to just increase funding and letting your offices identify what the right staffing levels would be for that? Just coming back from having that recommendation from the greater surge to be as specific as possible on what we're requesting. Do we just want to request an increase for the medical examiner's offices to be able to have adequate funding for complete toxicology testing and autopsies? Or would you find that that would be best served through XYZ, like through an epidemiologist or through a death scene investigator? Like, which one of those do you think you're lacking more? Or do you think that we're getting too far into the weeds if we, in a recommendation like that?
Again, I leave it to the committee about what is the most effective recommendation. I don't know that I'm an expert on that, but the death investigation part, I can tell you, yes, we need to adequately fund death investigators and the forensic pathologist to do the autopsy and the toxicology testing. And we would really love to have the added piece of the forensic epidemiologist. That's really important. And I know we've already talked about the bereavement piece, but really, if you don't have all those pieces in place, if you don't have a good death scene investigation, you don't identify up front that this could be a drug-related death. And so, when we're talking about death scene investigations, remember, we're also talking about our rural coroners going out and sending deputies who have no training in death investigation other than maybe a 2-day course they attended that my office gives. And trying to, parse out what they're seeing in someone's house and does it mean it's a drug-related death. So, we have a lot of different levels of death investigation in our state, but adequately funding and having an appropriate system to investigate those deaths is really the key to getting it right and having the correct data and being able to prosecute these deaths and not having, overdoses that are not being recognized and are not being investigated.
Thank you. I know I feel like I just had you repeat a bunch of stuff, but it helped me make connections in my head. So I don't know, Christine and the committee, I know this is Christine's recommendation. And I know we talked about dropping the family advocates and bereavement services and perhaps that being an additional recommendation, or perhaps maybe we can go back up to number 1, although we already voted on it, and see if we can't also provide that via medical examiners' offices. I don't know if we want to touch that with a 10-foot pole today, but I think for me, based off everything that we've heard, to get to both public health and criminal piece, what Crystal's written in there in that second to last paragraph, sans the, as well as family advocates and bereavement services, to me would be that specific recommendation would be to provide adequate funding for medical examiners' offices to include, because that you've got that also little piece down there at the bottom, and toxicology testing to determine specific causes of deaths. And I think maybe for me, that feels like as close to a specific recommendation that meets the original intent and also what the greater committee has asked us to try to consider. That's just me.
So you're
Christine,
saying just one
recommend-
recommend, oh, go ahead, Christine.
I apologize. I got kicked out and had to log back in, so I just caught the very last couple words that Shayla was saying. So if you wouldn't mind saying, it sounded like she was updating the recommendation, but I was booted out for a minute.
Yeah, Christine, I think that she was updating it to say that we should have the recommendation provide adequate funding for medical examiner's office to include death investigation or death scene investigations, forensic pathologist, forensic epidemiologist, and toxicology testing to determine cause of death. And then that, as well as family advocates and bereavement services. My only other question was, I know Dr. Knight had made a recommendation about maybe we should also look at the studying the compliance with that NRS 259.050 and 259.053. Because that's going to tell us a lot too, to see if we are getting compliance on the laws that are already in place. Did that answer your questions, Christine?
Yes, thank you.
Committee members, do you feel like we should include that study compliance with, or make a suggestion that a compliance study be completed? Maybe. Any thoughts from the committee members?
Dr. Knight here. I was just going to comment that I put those NRS codes into the chat in case anyone wants to see what they are.
Thank you.
This is Shayla Holmes for the record. It sounds like a separate recommendation for a compliance study to be completed. Would make sense based off of what Christine was saying in her attempts to get a hold of the Clark County Dr. Knight, and not knowing their processes. And so I think if it's unknown, if we're all doing the same thing, perhaps a compliance study might be beneficial to help us in the future.
And I would additionally say that compliance study may also have some impact or input into the ORF recommendation as well. So it sounds like that would be a separate recommendation that we would take back after our discussion is in addition to the one about providing adequate funding for medical examiner's office, is then the recommendation to recommend that a compliance study be completed on those two NRSs related to reporting or cause of death.
Christine, for the record,
go-
I would agree with that.
Thank you. I was just going to ask that. Christine, does that recommendation about providing adequate funding fit for what your intent was, or does your intent fit within that recommendation? Because again, I didn't want to speak for or water down your recommendation.
I think it fits. I mean, at the end of the day, like the doctor said, we want to know the cause of death, whatever it is. And then what that information is used for by either side of the fence is fine, because that's the facts are the facts, and they'll speak for themselves.
Thank you. So then we're making the two, it looks like a 5A, RS 5A and RS 5B. Do we have any further discussion, or are we ready to make a motion to move this forward with the two recommendations?
This is Shayla Holmes. I'd make the recommendation to approve RS5A and RS5B to move forward.
Thank you. Sheila made the motion for the recommendation for a 5A and 5B. Anyone second that motion?
Christine Face, and I'll second.
Thank you. We'll go for a vote then for our
Just a
original.
Point of order. I'm so sorry to interrupt.
No,
Dr.
go ahead.
Just a point of order. For 050, you may want to specify 050 number 3. There are a lot of numbers under that, and I don't want to have this committee initiating a study of all of those. It's 050 number 3. Thank you.
Thank you for that clarification. That helps. So with the amendments that we made for RS5A, recommend that a compliance study be completed on NRS 259.050 number 3 and 259.053. And then RS5B, provide adequate funding for medical examiner offices to include death scene investigation, forensic pathologist, forensic epidemiologist, and toxicology testing to determine specific cause of death. We'll go ahead and vote. All in favor, say aye.
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 Any opposed? Any abstentions? It sounds like that's unanimously passed. Dr. Knight, thank you so much for the clarification. You really helped us to get, I think, get a better recommendation than what we originally had.
It's my pleasure, and thank you so much for inviting me. I think this work is really important.
I agree. It looks like Christine has taken us down to where we need some additional, as we did with the prior recommendation, in terms of just a narrative on why we ranked this as we did.
This is Crystal for the record. Yeah, that's correct, Chair Kearns. We would want to have a statement, and I know the recommendation has changed, so these numbers may not be accurate anymore. And we also need a narrative. The impact of this would be the capacity and feasibility is something of that nature.
Is Rosalie on with us? Because my question was going to be whether we can fill the rest of that in, have a committee member fill the rest of that in after the meeting, send it to a committee member and have them fill it in. And I'm happy to try to do that.
We can provide the notes from this discussion, I think, which would help with how it's been revised. I don't think that we are voting on all of this information. I think we're only voting on the level of the actual recommendation. So.
Correct. Okay, and just out of lieu of time, we're almost to the end of our meeting, so I'm happy to work on that to fill in the narrative. Is that our last recommendation?
It is, yes.
Okay, so then that would take us on to back to our agenda, item number 5, which is discuss report out for December surge meeting. There, Vice Chair Holmes.
I have to apologize. I was in a bit of a rush getting here, getting to a place where I could be. I do believe the plan for the readout and discussion at the next meeting will be that Chair Kearns will share essentially what we've discussed today and the revisions that we've done in that report. And then the greater surge will have the opportunity to then rank again for the additional reporting that goes forward. And so I think the plan is to have that all finalized in December, since I believe this report is due by January. And so we won't be having any additional conversation at this subcommittee about these recommendations post this point in time. So this was our shot to get it forward. And then at the next meeting, the greater surge will see what we've changed, edited based on their previous recommendations and requests. And then from there out, we will see how it falls out into the report based off the greater surge. If I got that wrong, Crystal, please correct me.
No, you are correct. And I would just add for the committee members that the reason these will be re-ranked is because, as noted, we had 2 recommendations that combined recommendations from other committees. And I believe there's other committees that are combining some recommendations. So the ranking needs to be done again because of the work that we did today. So just for clarification. And now, are there any questions from the committee members on the process for the December surge meeting? Hearing none.
Chair Kearns, just perhaps maybe it will be very similar to the previous operation, right? So if committee members feel very strongly about your recommendation, please make sure that you're present and you'll have an opportunity to provide your comment in that period of time. So while Dr. Kearns will be presenting our overall findings, each of us have an opportunity to add to what Chair Kearns shares and engage in that conversation, and we're encouraged to do so.
Thank you for that. I think that's very important. I appreciate you adding that. So we'll move on to item number 6, which takes us to public comment again. Do we have to reread this? Crystal, okay. If anyone has public comment they would like to make, please raise your hand if you're on the line, or call in using that 669-444-9171. When prompted, enter the meeting ID 868-3331-1069 and press *9. I don't see any hands raised.
I don't see any hands raised. We do have one person joining only by phone, so that person would need to do the *9 or ask to be unmuted, and we can do that. And actually, I do see that they have raised their hand. So I'm going to ask them to unmute, and then Chair Kearns, if you want to call on that person.
Please, whomever is calling in, if you'd like to make public comment.
Yeah, this is Bryce Shields for the record. I apologize for being late. I was sent the information for the response committee Zoom, and so I attended their entire meeting. And then at the end of the meeting, I realized I was in the wrong subcommittee.
Oh, the prevention. You were on the prevention.
Right, I was in the prevention.
I'm so sorry.
No, that's fine. They sent me this Zoom this number so I could call into the Zoom. So I apologize for not joining until now.
No.
I don't know if I can provide any meaningful input on the discussion item. I know that Medical Examiner Knight was going to address the issue regarding allocating more funds for additional MEs to investigate overdose deaths. As a prosecutor for the last 15 years, I do have a little bit of insight on the supposed tension between the Good Samaritan Law and NRS Chapter 453. I would just note for the subcommittee's consideration that our Good Samaritan Law here in Nevada only only immunizes misdemeanors and Category E felony drug crimes. And all of those Category E felony drug crimes are either mandatory probation or they're mandatory diversion. The drug crimes that we're trying to capture by allocating more funds for medical examiners are the most significant drug crimes. Murder, a violation of NRS 200-020, child murder, when you have a child present during the commission of a drug crime and somehow drugs end up in that child's system and they die, or child abuse. It also doesn't immunize trafficking or possession with intent to sell. I think it's important to consider that for practical purposes, prosecutors aren't going forward on prosecutions for drug crimes related to that involve homicide unless it involves somebody who's high up on the chain of distribution. In 15 years, I've only had one opportunity to prosecute a homicide related to drug abuse, and I declined the opportunity to do so because it was one addict giving drugs to another addict. It just didn't make sense for practical reasons to go after one addict who had given drugs to another addict. If I had a circumstance where I had someone high in the distribution chain and that person was a known drug distributor and that person gave drugs to somebody and they died, then I would take the opportunity to do that. But these cases realistically are few and far between. And I think it's important that we equip prosecutors and law enforcement personnel with all the tools that we can possibly get to be effective when we have those opportunities to prosecute drug dealers who are actually causing drug overdoses. If there's any questions, I'm happy to take those.
Thank you for that input. We appreciate it. And I don't know if there's any questions. DA Shields was supposed to be here as an SME, but as you've heard, he was provided the wrong information. Thank you again for that. I think that helps because there was some question as to how many cases we were looking at in a year that this would affect. So you said you had only had one in your years.
Well, and that's from the perspective of a rural prosecutor's office. I'm sure in the larger jurisdictions, Washoe, Clark County, maybe even Elko and Douglas County, they encounter those a lot more. It's just, we've probably had 4 or 5 drug overdoses in the last 6 months in Pershing County, but it's hard to put those homicide cases together, even when we know that drugs have been provided by another person. It's just hard to effectively put a prosecution together. And that's one reason why I would support allocating more funding for medical examiners who are dedicated to investigating these types of crimes. It's just one more tool in our toolkit.
Thank you for that. Do we have any other public comment? Hearing none, we'll go to item number 7, which is adjournment. I would like to thank the committee members and our subject matter experts who assisted us today and the members of the community who joined this meeting. We'll now adjourn.